Assalamualaikum doctors, good evening. So welcome to our 12th session, and here we have a list of topics. So let's start with the first one. The first topic is breastfeeding, its contraindication. It's very important as far as our MCQs are concerned, because you will find so many questions where they have mentioned so many disease conditions, and they're just simply going to ask you whether are you going to advise the patient to continue for the breastfeeding, or you will ask your patient to stop breastfeeding. So mostly questions will say some disease condition, and then you have to think about whether this is the condition where we should ask the patient for the stoppage of the breastfeeding, or maybe the patient could continue the breastfeeding. Or there are certain questions in which there is mastitis, postpartum mastitis is there, and what are the treatment we are going to offer, and which organism is actually involved in causing that particular situation. So let's have a look of this breastfeeding from MTB. Page 974. Here we have this short topic of this breastfeeding. So we all know the benefits is going to enhance the infant gastrointestinal function, decrease the risk of infant infection. Of course, it's going to protect the baby from the infection. It has immunoglobulins, especially this maternal feed. Increased rate of maternal recovery is going to be there. The more uterus is involuted if the patient is going to breastfeed her child. Decreased maternal and neonatal stress, higher rate of maternal weight loss postpartum. So this again, weight loss is one of the good thing for the mother, especially whenever they want to involute their uterus, they should go for the breastfeeding. And again, of course, it's an important thing, the important feed for the baby. Now, decreased risk of maternal breast, ovarian, and endometrial cancer. So it's a quite suggestive studies that those women who are actually breastfeeding their child, they are less prone to get infections and less prone to get this tumor, especially as far as this breast, ovarian, and endometrial cancers are concerned. Decreased risk of maternal cardiovascular disease and type 2 diabetes mellitus. So there are again, there are the things which is going to add value to our patients. Now, this part is important. This contraindication part is very important for exam point of view. So we are going to stress more on this one. Like what kind of maternal diseases are there where we will ask our patients not to breastfeed their child. So first of all, HIV. So if the patient is a known HIV patient, we will never recommend our patients to go for the breastfeeding, because there's a risk of transmission, vertical transmission from mother to a child especially. So just remember, if the mother is having any kind of immune deficiency syndrome or known HIV positive case, we will not ask her, we will not encourage her to continue for the breastfeed. Plus, if the mother is having active tuberculosis, it's not like that in the past she was having infection. If now if you're saying that the patient is now in active state of tuberculosis, then only it's a contraindication. We will ask the patient, because she might be using and she must have to receive this anti-ATT, especially this anti-tuberculosis therapy treatment, and this type of treatment where we cannot control the timings and maintenance use of the drugs especially, and that is going to harm the baby. So just in order to avoid all this thing, we will never encourage our patients to go for breastfeeding. So we'll ask them to stop breastfeed and start bottle feed if the patient is having active tuberculosis and she's on an ATT treatment. Or if the patient is having active herpes virus, and especially that's a breast lesion. So if there is active herpes over the nipples of the breast of the mother, then only it's a contraindication. If herpes is there on oral side, like oral mucosa or lips are involved, then that's not a contraindication for the breastfeeding. If there is a herpes infection over the nipples of the breast of the mothers, then only it's a absolute contraindication for the baby, because baby is more prone to have infection because of this one. So we'll not ask for this one. Then we have maternal use of drugs of abuse. So if the patient is having if a patient is IV drug abuser, or the mother is on some kind of drugs which are actually causing a harm to the mother as well, so of course that's going to also cause harm to the baby as well. But it's less likely. But maybe if they are IV abusers or drug abusers, we will not advise them to continue for the breastfeeding. Or especially if the patient is on any cytotoxic medication. Cytotoxic medication includes any kind of tumor therapy. If the patient is receiving, say for example, methotrexate or cyclosporine. So if there is any ongoing tumor inside the body for which she is receiving this tumor therapy, or especially this chemotherapeutic medications, then only it's a condition where we will not ask the patient to go for the breastfeeding. So we'll inquire in our history if the patient is on having only any if the patient is taking any cytotoxic medications or not. So these are the very important points. So what are the actual infections which we will keep in our mind? Shall we close the door? So HIV infection, active HIV infection, active tuberculosis infection, and active herpes infection of the nipples. Plus, if the mother is IV drug abuser, or if the mother is on on any chemotherapeutic agent or tumor agents, where in the body she is having any active tumor and for which she's receiving chemotherapeutic medications. There is only one contraindication where we will not encourage her to go for the breastfeeding as far as the neonatal part is concerned, and that is galactosemia. If the child is a known case of galactosemia, then this is the only absolute contraindication as from from the baby's perspective, that we will not continue to give him the baby will not continue to feed the baby, especially the breastfeed. That's the only one neonatal condition. Rest are all the maternal conditions. Most of the time, you will receive the questions where they are only asking about the maternal things. So let's have a very recent recall. Look at recall. Okay. So here, the question says, a 28-year-old woman presents to the maternal health clinic and reports that she has not had a menstrual period for the past 2 months. Human chorionic gonadotrophin test positive. Her significant health history included a needle stick injury 1 year ago from a patient with hepatitis C. She was treated with interferon and has received monthly screening examination. She's asked if she would be able to breastfeed her newborn. So now she has just delivered a baby, and she's asking you that in the past, like 1 year before, I was having this needle stick injury. For that, I was taking this especially antiviral, and she was diagnosed with a case of hepatitis C. Now she's asking you for your advice, which of the following complication would most likely prevent breastfeeding. Now here they're asking, she asked if she would be able to breastfeed her newborn. So of course, if the patient was diagnosed with a case of hepatitis C, that is not a contraindication for breastfeeding. But here the question is asking, which of the following complications would most likely prevent breastfeeding? Now forget about the scenario. What is the scenario all about? Look for the answer choices and decide among these choices which of the following complications would most likely prevent breastfeeding. So do you think lack of routine newborn immunization is a contraindication factor? Of course not. If the baby is not immunized on time, that is not a contraindication that you're not going to breastfeed your child. Second, neonatal oral candidiasis. If the baby is having candidiasis, no problem. Usually the neonates do have, of course, this candidiasis, especially those who are bottle fed. So they must have this candidiasis because that's a fungal infection. If you're not, if they, of course, they are not doing brushing and all that. So they may have a chance to develop this candidiasis, but that again is not a contraindication for breastfeeding. Maternal anemia. So anemia can be, can be curable. You can cure anemia in the mother by advising this oral iron tablets. So of course, that is not a contraindication for breastfeeding. But this cracked nipples, of course, this is the contraindication right now. If the mother is having cracked nipples, the bleeding will come, right? So that is, of course, nobody will want that the bleeding, this especially bleeding nipples, if you're going to feed the baby. That we never want like this, right? We never want the mother's blood to be taken by the neonate. So what we can advise to the mother, if she's having unilateral cracked nipple, we'll advise that you should apply bepanthen cream or some ointments, and we'll provide supportive treatment, and we'll ask the mother not to feed the child from this breast, especially this breastfeeding. What you can do, you can just express the milk in the bottle, and then that milk you can give to a baby. Or if the nipple is so much cracked, just keep on bleeding, we'll advise not to do anything, just do the hot compresses, supportive therapy, and or a topical ointment you will give to your mother, and these cracked nipples will heal eventually within 48 hours and 72 hours time period. So that is not much a much time period where we can discontinue this breastfeeding. The point is, if the mother is going to breastfeed from the cracked nipples, the nipples are becoming more and more infectious. A day will come that this mastitis will become infectious mastitis. So we don't want that. So what we can do, we just ask the mother, if you see that the nipple is cracked, the pain is there, just stop feeding from that nipple, go ahead from the other side. And what we can do, we just provide supportive treatment, and within 2 days, within 3 days, the nipple will be healed, and then she will continue her breastfeeding. So here, your answer should be cracked nipples.
Excuse me, Dr. Hera.
Yes, dear.
In this case, the patient is a treated case of Hep C. If she was
Hmm.
an active case of Hep C, then breastfeeding would be contraindicated.
See, if she is an active case of hepatitis C, even that you are not going to stop the breastfeeding. You will just advise your mother that if she is having like on antiviral, so what we can do, we will just ask her to delay the breastfeeding 2 hours whenever she's taking antiviral. So she can take antiviral, and after 2 hours she can breastfeed the baby. That's again, it's not a contraindication. Only active TB, herpes infection of the nipple, and especially any HIV condition in the body, HIV positive now, or if there's any drug abuse history or any chemotherapy like tumor, that's only absolute contraindication. Otherwise, if the mother is taking any kind of medication, just ask the mother. Even if you are prescribing mother antibiotic for any reason, what we usually advise to the mother, just take your antibiotic, 2 hours gap should be there, and then again you can breastfeed your baby. Or in the meanwhile, if the baby is not taking, or she or the baby has already bottle fed, then just take out the milk, express the milk, and that milk can be utilized within 4 hours. She can just utilize that.
Okay, thank you.
So the next question says, a 25-year-old breastfeeding mother who delivered a month ago, present with fever and pain in the right breast for the past 2 days. Now she has already delivered a baby 1 month postpartum, and now she is having fever and pain in the right breast. So most likely she must be having this mastitis, or there may be breast lump is there. Lump is actually what? It's actually an engorged milk. So because of the engorged milk, sometimes that's going to create a lump, and the lump can be infected and it can become infectious as well. So the fever comes with chills and malaise. Now, on examination, the right breast shows a skin wound on the areola with a reddened and indurated surrounding area. Now, she is clearly having an infection. So, mastitis is there. And of course, because she's a postpartum period, she's in postpartum period, she's lactating. So, we will say it's a lactational mastitis. So, blood pressure is okay, heart rate is okay. Of course, she's having fever, so temperature will be raised. So, 39 degrees centigrade, the temperature is there, fever is there. Which of the following is the most likely causing pathogen? So what we should know first, what is the diagnosis? If we know the diagnosis of the patient, then only we can suspect that which organism is actually responsible. So for this one, I just wanted to take you to AMBOSS, where we can just quickly revise this lactational mastitis. See this benign breast conditions, where we have first of all this inflammation of the breast parenchyma, that term is called mastitis, and once she is in the lactating phase, we can say it's a lactational mastitis. So which organism is the most common? See, it's clearly mentioned the most common organism is Staphylococcus aureus. So Staphylococcus aureus, whenever they like on examination also, here in the question you have found that the patient is having infected breast. So of course the wound is there and wound is infected. So which organism is mostly responsible? Just memorize this one. It's a Staph aureus. That's a skin flora infection. Other pathogen can be E. coli and Streptococcus, but most common is Staphylococcus aureus. And for the diagnostic point of view, of course, the clinical diagnosis, and for the treatment point of view, if the mother is breastfeeding, you can advise your patient that you should continue feeding the baby from the other breast. And what you can do, you can just express the milk and discard from this side. But don't put the baby, don't latch the baby, and don't let the baby latch on this breast side. Cold compresses you will offer, and you will advise antibiotic, of course. So this oral penicillin, or if the patient is allergic to penicillin, dicloxacillin is the one which you're going to advise your patient. And if the patient is hospitalized, we can go for the vancomycin, or any methicillin resistant drug. But most of the time the patient will be on OPD basis, so you will just advise her any penicillin or cephalosporin. If the patient is allergic, you will go for dicloxacillin. So let's have a look at the question here again. Here the question was saying that she was having wound infection. Now they are asking for the organism. So which of the following is the most likely organism? So think about mastitis. Based on the finding, your diagnosis is mastitis, and you know very well it's in the lactating phase. So it's a lactational mastitis, and most common organism during this state is the Staphylococcus aureus. So your answer should be Staph aureus. And you have already seen this in AMBOSS. Okay, now this question. A full-term boy was born to a mother diagnosed antenatally with hepatitis B surface antigen, HBs AG positive. Now, the mother who has delivered a baby, during antenatal time period, the mother was Hep B positive. Her delivery was unremarkable, and the newborn weighed 3.4 kg and weight normal in assessment. Yes. He received the hepatitis B vaccine and hepatitis B immunoglobulins within the first 4 hours. This is the protocol. Whenever the mother is Hep B positive, what we usually do to the baby, as soon as the baby born, within 4 hours, the baby has to have, received this hepatitis B immunoglobulin, and baby has to be vaccinated. So that is the protocol, especially to those neonates which are born especially from the mother who are having Hep B positive. During antenatally, especially if the mother is hepatitis B positive, what we give to the neonate just soon after the delivery, within 4 hours, we have to give the baby immunoglobulins, and we have to give the baby vaccination of this hepatitis B. Now, the mother is very enthusiastic to breastfeed her child as she did with her previous children. Of course, we already read this one. Those who have joined late, just go through the MKB handouts and go through the previous recording. So it's clearly mentioned we have certain disease conditions, active diseases, where we will advise our patient not to breastfeed her child. But if the mother is having any other disease among those listed diseases, you just continue, or you just encourage your patient to continue breastfeeding. So here, hepatitis B is not a contraindication for breastfeeding. Only herpes infection of the nipple, only active tuberculosis, only HIV positive mother, only those mothers who are having any active tumor and they are on the chemotherapeutic or anti-tumor drugs, only there are certain absolute contraindications where we can discourage the patient not to breastfeed. But rest all the diseases, if the patient is having any kind of disease or on any antibiotic, no problem, she can continue the breastfeeding. But only if she's on antibiotic, she has to have 2 hours of gap after taking her antibiotic. There should be a gap of 2 hours, and then she can continue her breastfeeding. So here also we will advise our patient to go for breastfeeding. We will never discourage our patient, although she was a known Hep B positive. So we have already give prophylaxis to the baby. We have already given immunoglobulins to the baby, and we have already given hepatitis B vaccination to the baby. Now the baby is safe, and the mother can continue her breastfeeding. So we'll always encourage breastfeeding. Okay, for the next one, we'll go for the theory first. Next, we have eclampsia. So before eclampsia, we have to have knowledge about preeclampsia, because preeclampsia is actually having 2 or 3 conditions with it, and it can convert into eclampsia, especially only one. If scissors are there in preeclamptic patient, we can say that's a case of eclampsia. So 91.
Sí, صوتك راح فين؟
So here we have eclampsia. This one. So what is there in eclampsia? Eclampsia is defined as tonic-clonic seizure occurring in a patient with a history of preeclampsia. So first of all, we have to go for preeclampsia, because the one who is pre-eclamptic, and once she is presented with the seizure, especially this tonic-clonic seizures, fits, we can say now the patient is eclamptic. So for preeclampsia, we'll just quickly go through this preeclampsia. We have 2 types of preeclampsia. One is which is having which don't have severe features, and one which is having severe features. And what are the features? The patient must be having gestational hypertension. Remember gestational hypertension, the hypertension that can be occurring in any time period during pregnancy. It's not the previous actually hypertension which is continuing the pregnancy. Because of the baby at any time period, if the patient is having blood pressure, we can say it's a gestational hypertension. But if only blood pressure is raised no any other symptoms, we can say it's only gestational hypertension. But in combination with this increased blood pressure, if we have proteinuria, if we have mental status changes, the patient is having some visual changes, the patient is having right upper quadrant pain in the abdomen, there are certain conditions which are accompanied with the hypertension, then we can say the patient is pre-eclamptic. So now what are the features? So sorry, I'm just going to mute you, doctor. If you want to ask anything, you can just unmute and ask. So here, preeclampsia without severe features. So hypertension is there, and hypertension means that the one who is having BP more than 140/90. So if the blood pressure of the patient is recorded like more than 140/90, you can say it's one of the feature. But it's not very severe, like the BP is not very much raised. But if BP is more than 160/110, 110 diastolic, it's too much. So that is considered to be a severe feature. That is going to be included in the severe feature. Similarly, proteinuria, if proteinuria on dipstick is showing +1, +2, or you have, collected 24-hour urine and that urine is showing more than 300 milligrams of protein inside, it means that again, it's not very much severe. It is preeclampsia is there, but not severe. But in preeclampsia with severe features, not necessary for diagnosis once severe features are present. Sometimes we will find +3, +4 proteinuria in these severe features as well. But proteinuria must be there in order to make a diagnosis. Then mental status changes, of course, if you see there are some changes in the behavior of the patient, mental status is changed, patient is confused, think about the severe feature. Visual changes, if the patient is having blurring of vision, severe headache, think about severe features. And right upper quadrant pain again. So if there is right upper quadrant pain, some visual blurring is there, patient is confused, patient is having BP more than 160/110, you can say the patient is presenting with severe features of preeclampsia. But if only the BP is increased, proteinuria is there, but as such, no visual changes, no mental changes, no upper quadrant pain, especially on the abdomen, we can say still the patient is preeclamptic, but without severe features. Now, up till now, the patient is not presenting with any kinds of fit, only increased blood pressure, but this blood pressure 110, the patient is at risk of developing fit at any time. So what we have to do, as soon as we have recognized this one, we have to go for the treatment. Now, what kind of treatment you are going to give it to your patient? So if the patient is having mild preeclamptic features, or if the patient is having severe. So once you differentiated now that this patient is having mild features and this patient is having severe features. So the one who is having mild features and you think the mother is already at term, like more than 37 weeks, just induce the delivery. You can just take the consent from the patient, you will put prostrate, you will go for the induction of the labor. You told your mother that already you are at term, now it's a good time to deliver a baby. But what if the patient is less than 37 weeks gestation? So for example, in 30-weeker or 32-weeker or 34-weeker, what you're going to do, you have to first mature the baby's lung. And for that, you will give this betamethasone, this corticosteroid dexamethasone injection, 12 milligram intramuscularly, 2 doses apart, 12 hours, 2 doses apart. So you must give this, especially this steroids to the baby in order to steroid to the mother in order to mature the baby's lung. So first thing, you will do this one. And second thing, just to protect your patient from developing a fit. So that is called the seizure prophylaxis. Fits prophylaxis you will give. And what medication is there? That is magnesium sulfate. So we usually give magnesium sulfate. That is for prophylaxis. We know very well that the patient has not, up till now has not developed any kinds of fits. She's still under the category of preeclampsia. But as the baby is, baby is premature, your patient is still, in preterm labor or in preterm condition, what you will do, you will just give magnesium sulfate prophylaxis, because we have to wait. 30 to 34 weeker is a time period where we can deliver a baby, but it should be up to 37 weeks. But if there is any history of fit development before 32 weeks, of course we have to deliver a baby. But the prognosis of this survival of the baby's chances is very less in this condition. So just remember, guys, we have to give steroids to the mother just in order to mature baby's lung, and we have to give magnesium sulfate prophylaxis. But what if the mother is at term, like mother is 37 week or 38 week? No need to give magnesium sulfate. Just ask a consent, take a consent from mother. Just induce the delivery with the help of prostine. You can just dilate the cervix, and you will start syntocinon. You will just put your patient on syntocinon, and you will induce the labor. But what if the symptoms are severe, more than 110 diastolic BP? So you have to give magnesium sulfate, whether it's a term or it's a preterm. Don't wait, just start. You have to give this magnesium sulfate prophylaxis. You have to control the BP. For BP controlling, of course, we'll go for labetalol and hydrolysine. These are only IV medication. You have to admit your patient in high dependency unit, and we will always deliver a baby. If it's a preterm baby, give a steroid cover. And then deliver. And if it's a term baby, no need for the steroid, just give the max sulfate prophylaxis and deliver a baby. So think about if the BP is more than 160 by 110, if the baby, if the mother is at term or preterm, it will not be a matter for us. What we will do, we will just give the mother max sulfate and we deliver a baby. If it's preterm, we'll give DEXA cover first. We'll wait for 12 hours for the second dose of DEXA, and after 2 hours, we'll deliver a baby. And most likely, if she is a preterm, we'll go for the cesarean section, because for the induction, we don't have much time. We usually prefer emergency cesarean in that case. If CTG is reassuring and mother's blood pressure is getting down, then only you can induce labor. Otherwise, we will not take chances of waiting for the natural labor. So this is all about preeclampsia. Now, just have everything this in your mind, that the mother is having increased BP, the mother is having visual changes, the mother is having mental changes. Think about all these features of preeclampsia. Now, one add-on feature, now the mother has developed one fit. And there must be someone who is going to give evidence, who is going to provide evidence to you that I am evident there when she was developing a fit. So there must be someone who can acknowledge that the patient went into fit, and that should be a tonic-clonic seizure, and it comes, the patient comes to an emergency department. There must be some family member who's telling you a history that the patient had gone fit, and when you check the BP, it's of course more than 160 by 110, and already the fit history is there. Now the confirmed diagnosis is eclampsia. So what we will do, it's a tonic-clonic seizure must be there. Treatment first stabilize the mother, of course, then deliver the baby. We don't have time. We cannot put our patient for induction of labor. If already she's dilated, then only a chance we can wait. But if, of course, if it comes to you with 32 weeker, 34 weeker, 36 weeker, then we cannot wait for the induction of the labor. We have to deliver a baby through emergency cesarean section. So seizure control should be done with max sulfate and blood pressure control with hydrolysine. But whenever we are controlling the blood pressure, that the vigilant monitoring should be there, because we cannot drop the pressure at once. It's not like that the patient is having 110 diastolic BP and you give doses of hydrolysine that drops the blood pressure soon from 110 to 80 millimeter Hg. It cannot be like that. You have to decrease the blood pressure slowly. Other than that, what will happen? It will going to cause cerebral edema of the patient, cerebral edema inside, especially inside the cerebral edema of the mother. So that is what cerebral edema is, one of the thing which we need to prevent. That's why we are actually lowering the blood pressure slowly. But our main goal is to decrease the blood pressure from 110 up to 90 at least. For that reason, we have two options. We can give labetalol continuous infusion. We can give hydrolysine. Most of the time, hydrolysine shots are good enough to control the BP. So now let's have a question. Look at the question. Here the question says, a 34-year-old gravida for periatry at 32 weeks. So now she's 32 weeker, presented to the emergency department with tonic-clonic convulsion. So already she has undergone fits. Temperature is okay. Blood pressure is 140/95. See, the blood pressure is not that much, but she has developed a fit. Now she's coming under the heading of eclampsia. You have to diagnose her as a eclamptic patient because she has undergone a fit. Respiration is okay, pulse is okay. What is the most effective drug to control her seizures? So once the fits are there, we have only one. In case of preeclampsia, we were using as a prophylaxis, and now here when she developed a fit, that's the only treatment we can give in order to prevent a second attack of fit, and that is max sulfate. So we have only this one, magnesium sulfate. Why magnesium sulfate? This magnesium sulfate we are using just to control the fits. If they're asking you which of the medication we are going to control, BP, blood pressure. So if the blood pressure is, for this condition, the blood pressure is almost okay, we are not going to decrease it much. So other than that, if the blood pressure is mentioned here 160, 110, then you have two options, labetalol plus hydralazine. Okay. For the next one, we have to go for the theory first. We will do this measles, 888. What's the page number of this one? 959. Let me correct this one. And here we have 888. Okay, so for this measles, we don't have much detail, but whatever the detail is there in MTB, that is quite enough in following the recall. So this measles, you can say the other name of measles is rubiola. So rubiola is mentioned, or measles is mentioned, means the same thing. It's caused by paramyxovirus. Now, for the diagnosis of measles, just think about the symptoms of 3 C's. If the baby is presenting with to you having cough, having coryza, and conjunctivitis, so these 3 C's actually is pointing towards and making a diagnosis of measles. And not only this, when you do the examination, just one second. Yeah. So when you do the examination, especially when you look over this buccal surface, mucosa of the buccal surface, there you can see some grayish spots, or sometimes whitish to grayish spots, and those spots are called cup-like spots. So that's a very usual, very common finding and usual finding in measles patients, especially measles in children. What we do first, we look for the symptoms. If the baby is having cough, baby is having inflammation of the especially buccal mucosa, that's called coryza, and if the baby is having conjunctivitis, you can clearly see the eyes are red. Plus, once you examine the oral mucosa, you will see, especially on the buccal mucosa surface, there are some whitish and grayish spots, and usually they are on behind the molar teeth. So that spots are called cup-like spots. So on examination, if you find cup-like spots, on examination, if you find these symptoms, then you must have to make a diagnosis of measles. So that's a clinical diagnosis, and most accurate is measles. When you go for the immunoglobulin testing, antibody testing, you will clearly get to know that's a measles infection. And what we will do, because it's a viral infection, we only go for the supportive treatment. Whatever the symptoms are there, you will just go for the symptomatic treatment. If cough is there, you will provide antipertussive. If coryza is there, anti-inflammatory. Conjunctivitis is there, we'll just put topical antibiotics. So just only symptomatic treatment, supportive treatment, and the baby will be doing fine. So symptomatic presentation plus this cup-like spots on examination, these two are the important findings in order to make a diagnosis of measles. Let's have a look at the questions. Here the question says, a 6-year-old child present with a high-grade fever, malaise, conjunctivitis, coryza, cough. So he's a child, conjunctivitis is there, coryza is there, cough is there, coryza is inflammation of the buccal mucosa. So if these 3 C's are there, so just back in your mind, it must be a measles. Now, a rash of discrete pink macula recently begun on the face and extend to the hands. So rash start from the face, now extending down to the hands and the feet. The child also had small whitish spots inside the mouth before the rash appeared. So of course, measles rash will be all over the body, but before developing the body, the baby is having some whitish spot inside the mouth, and these whitish spots are actually what? They are the cup-like spots. Which of the following is the most likely diagnosis? So based on this whitish spots, based on the presentation of 3 C's, the diagnosis should be measles. That's a clear diagnosis. Now here also, a child is brought to pediatric clinic with cough, fever, rhinorrhea, malaise, and conjunctival erythema. So cough is there, rhinorrhea is there, buccal mucosa, nasal mucosa inflammation can come with rhinorrhea and coryza as well. Conjunctival erythema, conjunctivitis is there. There are small grayish irregular lesions surrounded by an erythematous base on the buccal mucous membrane. Now here the second finding is also there. or especially near the second molar teeth, which of the following is most likely diagnosis? Of course, it's a clear case of measles. Why it's a clear case of measles? Especially based on the symptoms of 3Cs, plus the baby is having this cough-like spots. So it's a clear-cut diagnosis of measles. For the next question, we have to go for the theory first. Then we have this Measles diverticulum. Let me show you an MTB first. 873. Okay. See, Measles diverticulum, and especially this Measles diverticulum, it's a true congenital diverticulum by birth will be there, in which the vitelline duct persists in the small intestinal tract. So this vitelline duct actually, once the baby is forming during embryological development, this vitelline duct should be disappeared. It cannot be there in the adults, or you can say in the baby once the baby is formed. So during embryological phase, vitelline duct is there, but soon after delivery, once the baby is formed, this duct should be, obliterated. But if it's there in the small intestinal tract, it can lead to the formation of diverticulum. And what is the most important point for the diverticulum, which we need to remember, that diverticulum is just like a blind pouch. You can just, put something inside that pouch, and that pouch has only one end from where the filling can be possible, but it has not the other end from where the things can go. So what will happen if something is keep on coming inside the diverticulum, what will happen? The outpocketing will be there, and that portion will become enlarged, and a time will come that it may burst. It may burst, and it can cause infection a lot. So most of the time, what happened? There's a small intestine who's having this vitelline duct, persistence of the vitelline duct, and that cause actually diverticulum, because the small intestine content will be going, inside this diverticulum. So this diverticulum will get infected, this diverticulum will get inflamed, and that will cause pain to the baby. And because it's a congenital one, so soon after delivery, maybe within years, the baby can have this diverticulum. The baby can present with the features of diverticulum, or maybe within few days, the baby can present with the feature of diverticulum. So we should know what are the presentation by which we can see, or we can suspect that this is a case of diverticulum. So the classic presentation is with painless rectal bleeding. What is happening most of the time when the mother comes, the baby is like 1 week old or 2 weeks old. What they usually say, they say that when we are actually changing the diaper, suddenly we come to see that there are some reddish, fresh red spots, blood spots are there inside the diaper. So, when they're changing diaper, they usually notice this red bleeding is there, or red bleeding spots are there. Otherwise, the baby is totally fine. The baby is not crying at all. There is not, no change in the baby. It seems the baby is not in pain, but from where the blood is coming. So that is the one clue that should click in your mind whenever the mother says to you that my baby is perfectly fine. He is taking, milk, breastfeed. He's taking breastfeed. He's doing potty. Everything is normal. Urine is okay. But sometimes when I change diaper, I get to see some red, fresh blood spots. So think about this diverticular. So what we can do, we will see next. But most of the time, the finding is like this one: massive, frank, bright red blood per rectum. See, it's a massive, frank, bright red. Most of the time, when the bleeding per rectum is there, and bleeding from the umbilical cord is also there, then we think about hemorrhagic diseases of the newborn. When the baby is having vitamin K deficiency, they usually present in this way, that the bleeding is also coming from the rectum, bleeding is also coming from the nose, plus the most important site is the umbilical cord. So don't confuse this diverticular rectal bleeding with the hemorrhagic bleeding of the newborn. That hemorrhagic disease of the newborn, because of the vitamin K deficiency, everything will be bleeding. The nose will be bleeding, the umbilical cord area will be bleeding, the rectal bleeding can also be there. So that is the hemorrhagic disease of the newborn. That is because of the vitamin K deficiency. But if it's a diverticular bleeding, it's a macral diverticulum, then only you will see bleeding per rectum, and that will be massive, frank red bleeding. Now is due to gastric acid secretion by the ectopic tissue causing searing of the nerve. Why is this all happening? From where the blood is coming, actually the blood is coming from the small bowel tissue. There is actually what is happening here, the gastric acid secretion by the ectopic tissue causing searing of the nearby. So this small bowel is actually getting irritated and the bleeding is coming from that side because of the presence of this diverticulum. So that is the main pathophysiology of this one. Now, there are certain rules for mecal diverticulum. Most of the time, 2% populations are involved. This only, for our exam point of view, there are certain clues which will give you, give you a hint that this is a case of diverticulum. Say, for example, occurs 2 feet from the eocecal where 2 types of ectopic tissue, gastric and pancreatic tissue, you can find here in this diverticulum. Male patients are 2 times more affected. But in your recall, in your MCQs, you will not get anything like this one. A part of this one only on examination, where you can find this one about 2 inches long, and most of the time it's 2 centimeters away from ileocecal junction. That's a typical point where you can find this metal diverticulum. Plus, if appendicular mass is there, you can also find appendicular mass in such a way. But there are some rules of twos, but it's not going to add value to your solving MCQs, because in MCQs you can never find something like this, because most of the MCQs will say the presentation of the child and what you're going to suspect. So how you're going to diagnose your patient if the baby is having this Meckers diverticulum? The most accurate test will be this technetium scan, that is called 99M scan. It is so accurate that it has been dubbed as Mackle scan. So we are not saying this as technetium scan. We just changed the name of this technetium scan to Mackle scan. Or surgical removal of the diverticulum is the only curative therapy, because we are not going to remove this diverticulum. It will keep on expanding, and there will be lots of damage to the small intestine. So we can just surgically remove remove this one if the baby is having this massive problem. The patient, or if the metal diverticulum is asymptomatic, you will not do it. Even if it's asymptomatic, you will never get to come to know that the baby is having this diverticular problem. Only when the symptoms are there, then only we'll go for the Mackle scan, because Mackle scan is not a routine screening testing, right? We usually don't perform that. So as soon as we have the complaint symptoms of the baby, then only we can go for Mackle scan, and once it's confirmed, you will go for the surgical option. And for surgical option, the baby should be at least we will see the condition of the baby. If there is too much bleeding, then of course we will do as soon as possible, or maybe we can just delay for some period of time. But if it's a massive frank bleeding, you don't have any option. You have to go as early as possible for the surgery. So now looking at the questions. Here the questions say a 3-year-old boy presents to the yes, dear.
This microverticulum cannot happen in adults.
It can. See here, it's happening in 3 years also. So maybe it's adults also. Say most of the time, because it's a congenital one, right? So congenital means by birth they are having this one. Now the things are not going inside. It's not getting irritated. It will not show any symptom by any age. If the diverticulum is started filling, the small intestine content is going into the diverticulum, and then the diverticulum will get inflamed. There is a passage, only things can go inside, and there is no passage from which the things can coming back. And inside the diverticulum there is no iobash flaxus, there is no peristaltic movement, nothing is there. So once the stool, or you can say the content of the small intestine is stuck there, it will remain stuck there. So what will happen? It will be inflamed, and then the patient must be having symptoms. And then you will come to know, okay, the patient was having this metal diverticulum, but this is the time where the patient diverticulum is actually inflamed or gets obstructed. Then you will get to know. But most of the time, because it's a congenital one, so early in infancy, early in childhood, you will get to know. So most of the time, the patients which you are seeing in your MCQs will be 5 years old, 3 years old, maybe 2-week old child, something like that. But it may present in adults also, just like appendix can be in children and can be an adult, same like that. A 3-year-old boy present to the clinic.
But in the above statement, they are saying it happens in the less than 2 years old.
Because it's a most common observation that we are usually finding that this is happening, but it's not hard and fast. No? It's not 100% correct that you will always find this diverticulum in less than 2 years of age, because it's a congenital one. So early you will get to know, but it's not hard and fast. It can occur in any age. Okay. So So a 3-year-old boy presents to the clinic with blood in his diapers for 2 days. Now see the presentation, 3 years old, blood is there in the diaper. There is no associated abdominal pain or constipation. It means that the patient is not having any symptom apart of this having this bleeding. He had similar presentation 3 months ago. The physical examination shows pale conjunctiva. Of course, if there is bleeding continuously, the patient must be having low in hemoglobin count and dry oral mucosa. Blood pressure is this one. Heart rate is okay in 3 years old boy. The respiratory rate, temperature is okay. Which of the following is the most likely diagnosis? So, if there is no, if they didn't mention something related to CBC count, platelet count, and so we will never think about any blood disorders here, because the things are not there in order to make a differential diagnosis. But owing to the presentation that there are no symptoms and still the patient is having this bleeding, or especially diaper bleeding, where they're saying this the age of the patient, and because of the bleeding, of course, pale conjunctiva will be there, the anemia will be there. So which of the following is the most likely diagnosis? Now, among the answer choices, you will get to know that, okay, what should be the answer here. So do you think it's a juvenile polyp, or it's intersusceptions, or Hispring disease, or Measles diverticulum? For juvenile polyp will never present like this. If it's a polyp, infected polyp, then the patient must be having this abdominal pain. But rather than that, their polyp is not associated with, or especially abdominal polyp are not associated with bleeding. Intersusceptions, that is the different, entirely separate entity, where we will see this steady-like stools and something different. So presentation will be totally different. So of course, it's not intersusceptions. Hispring disease, again, it's one of the neuronal disease, where we see the peristalsis is getting lost, and it usually happen, in just 24 hours old baby or 48 hours old baby, where the baby is actually not passing meconium at all. Usually the baby should pass his first stool during 24 hours, or up to 48 hours we can wait. But till 48 hours, if the baby hasn't passed the meconium, it means that there is something wrong inside the bowel of the baby, and that usually we will come to know that the baby is having megacolon, or the baby is having this Hispring disease, where actually what is happening, this myenteric plexus, Auerbach plexus, they are actually lacking. There is a deficiency or lack of Auerbach plexus, and because of this motor deficit, this neuronal plexus deficit, the peristalsis is not there. The peristalsis is not there in the distal bowel, in the large intestine, and that's why the baby is not able to pass the meconium. So then we will say, okay, it's a Hispring disease. So for Hispring disease, the baby should be 24 to 48 hours old. It's not like that the 3-year child is presenting with Hispring disease. So of course, it's a clear case of Measles diverticulum. And that's a great, there should be no any bleeding, blood disorder here. Say, for example, it's not mentioned here sickle cell anemia, it's not mentioned here iron deficiency anemia, because we cannot say, or we cannot comment on any blood disorder without having the reports of CBC in our hand. If we don't know the count of MCV, if we don't know the count of hemoglobin, if we don't know the count of platelets, we can never ever make the diagnosis of any kind of blood disorder. So that's a great thing. We don't have any option like that. Otherwise, it will be difficult for us. Among these choices, of course, based on the presentation, it's a clear case of Measles diverticulum. Okay, for this one, we'll go for the theory first. Now we have this Hispring disease, 863. So for this disease, again, it's a congenital disease, congenital lack of innervation of the distal bowel by Auerbach plexus. Auerbach plexus, the another name is myenteric plexus. So you can say myenteric plexus, you can say Auerbach plexus. These are actually the plexus of the small bowel plus large bowel. And what is the main function of these plexus? They are actually involved in the movement in the small bowel and large bowel movement, that is called peristalsis. So you can think always that whenever these plexus are working fine, the peristalsis will be there, and because of the peristalsis, the normal flow of the stool will be there, and the normal passage of the stool will be there, because there are host striations, there are peristalsis in the normal. So these plexus are responsible for maintaining the peristalsis inside the body. Now it's a congenital one, so soon after delivery we have to see this one. That's why 24 hours is a time period where the baby has to pass the first stool, that is called meconium. Meconium has to be passed from inside, especially from the body of the neonate, and that is all because the peristalsis is there and you want to see that the peristalsis function is everything is okay. But if there is lack of innervation of this Auerbach plexus because of the congenital anomaly, then what will happen? The baby will not be able to pass meconium. So this lack causes a constant contraction of muscle tone, because once the Auerbach plexus are not innervated, are not functioning well, or there's a lack of Auerbach plexus, then what will happen? There will be no peristalsis. So there is frequent association with Down syndrome, and it is more common in boys than in girls. So you can see the relation 4:1, 4 times more common in boys as compared to the girls. And we can see normally this type of head-sprung disease in combination with syndrome. So say for example, Down syndrome is having the most relation with the patient is usually presenting with this one. So what is actually the presentation? The presentation is this one. Of uninfected infant, 90% first meconium should be passed within 24 hours. That's a common observation. The baby has to pass his first stool, that is called meconium, within 24 hours. Whereas children with this disease do not pass meconium for over 48 hours or fail to pass meconium at all. Why? Because there is no peristalsis. Why there is no peristalsis? Because there is lack of innervation of Auerbach plexus. Auerbach plexus are not actually innervating the distal bowel, and distal bowel where the meconium is there, and there should be peristalsis, and because of the peristaltic movement the meconium will pass. But if there is no peristalsis, then the meconium or the stool will remain inside. So extreme constipation will be there, followed by large bowel obstruction. Rectal exam shows an extremely tight sphincter, and inability to pass flatus is also common. But what we usually see once we just once we do the rectal examination, once the doctor is going to pass his fingers inside the rectum, then upon entering the finger, soon after removing the finger, the baby just passed the flatus, and the baby, the lots of amount of stool will be coming out as soon as the finger is removed. So that will give you a clue that there was obstruction, and just by introducing the finger, the plexus is innervated, the upper plexus is innervated, and the parasympathetic activity generates, and what will happen? The baby just passed the stool. So what we can do? The only surgery is the option, and what kind of surgery is there? We have to analyze which part of the area, which part of the large bowel is actually not innervating, and that area we have to remove, and we have to do the end-to-end anastomosis. So we have to remove that area, otherwise the baby cannot pass the stool anytime, anyway. It's not possible the baby can pass the stool because that area is actually not doing peristalsis. So the peristalsis is there on the upper side, the peristalsis may be there on the lower side, but if in the middle the peristalsis is not there, the stool will remain stuck there, and the baby cannot be, the baby will not be able to pass that thing. So we have to cut that area end to end, and we have to anastomose each other. So that's called end-to-end anastomosis. So how we are going to diagnose this one? Of course, we'll go for the plain X-ray. We will see distended bowel loops. That will give you a clue that the bowel is actually accumulating stool inside, and there is no peristalsis. That's why the stool is not going out. With the lack of air in the rectum, contrast enema will show retention of the bedding for greater than 24 hours. When you do manometry, you will see increase and high pressure in the anal sphincter. The mainstay of diagnosis is full thickness biopsy that reveals a lack of ganglionic cells in the submucosa. So that is actually the true thing where you can see why is there any innervation of the Auerbach plexus or not. So once you do the biopsy, you will see there is no ganglionic cell inside, no ganglionic cells of Auerbach plexus. So no ganglionic cells are there. It means that the lack of innervation of the neurons, lack of innervation of the plexus, it means that we have to remove that area, otherwise that area will never undergo peristalsis, and that area will remain carrying the stool for a longer period of time and will get infected and will get distended, but there will be no release of the stool from that area. So of course a 3-stage surgery procedure is curative. What we will do, we will just remove that area which has no ganglions, which has no innervation of Auerbach plexus. We just cut that area and we will do the anastomosis. We will cut the intestine from where we can find no ganglions, and we will just anastomose the other two ends. So that's the only treatment we will do. So if we look at the questions here, so most of the time in your MCQ point of view, you will just memorize that what should be the presentation of the baby, or how the baby is going to present. and you just need to make a diagnosis of that one. So here the question says, a 10-day-old full-term boy presented abdominal distension for 1 week. Now he is already 10 days old. It is associated with greenish vomiting and difficulty in passing stool. Once the vomiting is greenish, it means that there must be some obstruction somewhere in this intestine. His stools are loose in consistency. On rectal examination, the rectum is empty and he passed large amount of stool and gases after the finger was removed. So the rectum is empty means that there is something on this distal bowel which is actually obstructing, or the distal bowel having something. The lower part of the rectum is undergoing obstructions, and you will see the lower part of the rectum is perfectly fine. That's why till 10 days the mother was never complaining about something, because the baby is continuously passing something. Why passing something? Because there is no proper innovation, but there is some innovation, of course, and because of that the rectum is actually functioning properly. The some upper part is actually obstructed, must be obstructed. That's why the patient is having vomiting, and that's why the patient is continuously passing some loose stools. But the proper passage of the stool is not clear. There must be something inside the bowel which is obstructing, which is actually dilated. There is no peristalsis over there. That's why the baby is not passing adequate amount of stool. And how you will come to know this one? Because as soon as the doctor removed his finger, what will happen? There is a large amount of stool and gases are released. So by introducing the finger, we are actually stimulating the parasympathetic activity. And by stimulating the parasympathetic activity, the gut will become functional, and peristalsis is there, and all the fluid, all of the things which are there inside will come out. So that is by inducing peristaltic wave. By inducing peristaltic wave, you see that the contents are coming out. But beside that, there's fully loaded inside. Something in the middle. It's not absolutely down, it's not absolutely upside. So it must be a distal bowel. So which of the following is the most likely diagnosis? So what do you think? It's a pyloric stenosis? Only by seeing this greenish vomiting, you can think about pyloric stenosis, because in pyloric stenosis, the patient is also presenting with this greenish vomiting. But that has nothing to do with the stool, or that has nothing to do with the rectal examination. And soon after the examination, the passage of the stool and all that, you will not see any type of thing there. Intersusception, again, of course, it's one of the things we will see later on, that has separate symptoms and everything. That should be there must be some different presentation. So we are not going into detail right now, but it has severely different functions and different symptoms and presentation. Incarcerated hernia, there is nothing related to hernia here. No, because there is no signs of hernia or any protrusion, something like that. And above all, the baby is just 10-day-old. If we have to see any type of hernia in the baby who is having, just an infancy age or neonate, like 1 month old or less than 1 month old, we usually found having this umbilical hernia or parambilical hernia, which is very less likely also. So usually we don't find any kind of hernia in the babies. So of course, then among these choices, what you will choose here? H-Sprung disease. Why? Because based on the symptoms, like there is some vomiting is there, it means upper obstruction is there, and rectum is empty. So if there is the lower obstruction, what you will see? You will see the rectum should be full as well. But if rectum is empty and the mother was not complaining any kind of severely constipated baby, and it's already the baby is 10 days old, it means that there is passage of a stool, but that should be very loose stool, like it's mentioned here, loose stools and consistency. Because some part is working, some part is not working.
Pyloric stenosis actually after 6 weeks, you can diagnose after 6 weeks. And
yes, after
intersusceptions occur about 8 to 1 year, 8 months to 1 year, and
yes, for intersusception,
of lungs and usually boil.
Yes, exactly. That is also.
What is the other thing? Intersusception and what about एक साथ एक और होती है, वो कौन सी होता है? Intersusception and what was another?
I don't know what exactly. Just tell me the symptoms. Maybe I can get an idea.
The red currant jelly stools and all that.
Mostly intersusception we have in which there is intestinal obstruction. So any kind of other like gastroschisis, omphalocele, there are other intestinal obstruction. So maybe you're talking about gastroschisis, or you're talking about a Scoliosis or intersusception. Most of these terms will go together.
No.
They're all intestinal obstruction.
No. Another term is another thing is another. I don't remember.
Doctor, are you talking about volvulus?
Yes.
Okay. That is the mid gut rotation. Yeah. Okay. So again, it's again one of the kind of intestinal obstruction. Yes. Okay. So here it's a clear case of Hintzman disease.
Dr. Hira, how incarcerated hernia will present?
So incarcerated hernia, it's, think about the outpocketing of this gut, and that gut is actually necrosed. So that is incarcerated hernia. But in 10-day-old, you cannot see something like this one. Even though if its hernia is there, that is the loosening of the hernia, we only see an umbilical area. So that should be there in the symptom. That should be there in the question if it says. But incarcerated one, it will take a lot of time. Hernia incarceration cannot happen in a day or two, maybe not in a week as well. It will take a lot of time. When it was long-standing hernia, like in years, then only we can see.
Okay.
So the next question, we have to go for the theory first. Bronchiolitis. Okay, that is not very much in detail in MTB, so we'll go for the AMBOSS. Okay, so for bronchiolitis is a lower respiratory tract infection. We should know what are, who is coming under upper respiratory tract infection and lower respiratory tract infection. So of course the bronchioles are involved. So this is the lower respiratory tract infection in which the bronchioles become inflamed because of viral infection. And most of the time the virus is RSV virus. Just memorize this one because mostly they're asking us, the common pathogen which is involved in developing this bronchiolitis. That is RSV, that is respiratory syncytial virus. The infection occurs mainly in children below the age of 2 and is characterized by initial upper respiratory tract symptoms. So what are the upper respiratory tract symptoms? The patient is having low-grade fever, there will be stuffy nose, and then later on we will see followed by a cough and possibly signs of respiratory distress. So what are the signs of respiratory distress? Whenever the patient is having too much respiratory rate, tachypnea is there, wheezing is there, nasal flaring is there, some intercostal retractions you can see on examination. The baby is bluish because of oxygen hypoxemia. Cyanosis is there. So whenever these signs are mentioned, always think about these are the signs of respiratory distress. So starting with the low symptoms, starting with the upper respiratory symptoms, there is only the low-grade fever and stuffy nose, but soon the baby is having cough and soon the baby is having signs of respiratory distress, like the baby's respiratory rate is too much high. You can appreciate the wheezing inside the baby. Nasal flaring is there. On examination, you can see intercostal retractions are there. And the baby is also hypoxic and hypoxemia is there. Cyanosis is the presentation. So these are all the signs of respiratory distress. So your baby can have respiratory distress because of this bronchiolitis. Now that may require hospitalization. Of course, once the respiratory distress is there, we have to hospitalize the baby. Ill children should be closely monitored and receive oxygen and proper hydration for supported therapy. Yes, dear.
But these are the same same like asthma.
Same like asthma? No. In asthma, what is the main reason? In asthma, we have especially these retraction things, like the air is actually getting trapped and there is no way out. So there the shortness of breath is the main presentation which we have, the chest tightness will be there. So mainly there the shortness of breath is the main thing, and hypoxemia and hypoxia will be the features, and retention of carbon dioxide will be there. But here in bronchiolitis, especially the inflammation of the bronchioles.
No,
there is no air trapping, there is nothing.
Hypoxemia and air trapping.
Yes, so these are the aggravated things. The baby must not be presenting with all these things, but if the infection is too much, then of course if all bronchioles are involved, then only you will see this respiratory distress. Yes.
No, we have,
but there is no air trapping in the.
These are the signs.
Yeah. So see, this wheezing and all these things, these are the symptoms of respiratory tract infection. So whenever any kind of respiratory tract infection is there, you will always find these symptoms. But these are reversible ones. Once the infection gone, the symptoms will go. But here in the case of asthma, it's not like that. It will be, of course, it will keep continuing because it has nothing related to the infection. There is no virus who is actually causing asthma. Okay, that's a tract disorder.
There may be history of asthma, allergy, and on the exposure to cold or exercise or something like this. Asthma.
Yeah, that also you can say. Yeah, associated factors are there. Exactly. So here you will see what are the clinical features initially present with upper respiratory tract. You know what are the upper respiratory tract infections, like symptoms. Rhinorrhea is there, low grade fever is there, cough is there, and then as soon as this all finished, the baby can develop aggravating symptoms. That is symptoms of respiratory distress, and these symptoms we have already mentioned. And of course, the baby is not going to take proper feed. There will be poor feeding history. When you do the auscultation, you will find crackers. You can appreciate wheezing, especially on examination. So now here the very important point for you to memorize this one: an upper respiratory tract infection followed by symptoms of respiratory distress. So the mother must be, giving the symptoms like this, must be saying that the baby was having some initial, coughing was there 2-3 days and running nose was there. And then soon after the baby is developing this wheezing and the symptoms are aggravating day by day, especially the baby is less than 2 years of age, always think about bronchiolitis. So that is only a clue for you. So how you're going to diagnose your patient who are having bronchiolitis? It's a clinical diagnosis. Once you go for the nasopharyngeal aspirate, you will find this RSV virus on the smear. Chest X-ray, when you do, you will see hyperinflation of the lungs. You will see interstitial infiltrates. Sometimes you can see atelectasis also, where you can see actually a loss of lung volume caused by deflation of alveoli, and especially these bronchioles are not going to have air inside. There may be a collapse, especially occurred in lungs. And most likely atelectasis we will see soon after operative procedures. So any kind of patient, once he has undergone any kind of surgery, soon after surgery, within 24 hours, atelectasis can be there in a patient. Where what is happening? The lung is actually collapsed. And why the lungs is collapsing? Because the alveoli, they are not actually, they are deflating. They are not able to capture air inside, because the patient is having, on anesthesia affected there, the patient is lying down. That's why it's very important soon after surgery, we have to go for spirometry, especially those patients who are having respiratory problem before as well. But here, it's showing that chest X-ray can show you these symptoms, but these signs especially you can appreciate, but not of course atelectasis. That will be the very last thing you can observe. But most of the time you can observe hyperinflation of the lungs. Why? Because too much trapping is there. So most commonly, bronchiolitis is a clinical diagnosis. Once you do the clinical diagnosis, you actually don't need any kind of this thing. But of course, these are the things which will help you in making a diagnosis, correct diagnosis. So what treatment you are going to give to your patient? So pharmacology, we can give bronchodilators, epinephrine, steroids have historically been a part of the treatment for bronchiolitis, but recent guidelines recommend using such therapies mainly in severe cases. So we'll never go for steroids and epinephrine bronchodilator until and unless the patient is having this respiratory distress symptoms, because the virus, it's a viral infection, so better we go for antivirals. So antivirals, ribavirin, currently not recommended for routine treatment for bronchiolitis, may be considered an immunocompromised patient. So here again, they are saying in immunocompromised patient we can give. So what we will do, we can just support the baby. How we are going to support? If there is dehydration, we will hydrate the baby. Relief of nasal congestion. If there is too much rhinorrhea and nasal stuffy nose, we will just relieve the congestion. We'll just monitor the baby. And if there is any indication for hospitalization, say for example, the baby is not feeding at all, the baby is dehydrated because of the lack of feed, baby is lethargic, we can just admit the baby. If the baby's age is less than 12 weeks or history of prematurity, we can admit this baby. If the baby is having any kind of immunodeficiency, if any other comorbid disease is there in the baby, we have to admit the baby. So this is the admission protocol. But they are saying we should not give antiviral until and unless we are saying if the symptoms are too much or maybe considered an immunocompromised patient. Those baby are immunocompromised, there we can give antiviral. Other than that, we know very well virus is having the time period. The life cycle of virus is approximately 48 to 96 hours. So whatever the state of there, that should be eliminated within 96 hours. Most likely, we usually consider that the virus should be resolved after 48 hours. So that time period, we can just support the baby. No need to go for any other treatment because it's a virus. It will complete its life cycle within 48 hours and maximum 96 hours, and then it will go on. So in the meantime, we can just support the baby. And if we find anything for which we have to admit the baby, say for example, if the baby is too much dehydrated because he is not taking proper feed, we will just admit the baby and hydrate the baby. So if we look here at the questions, they're saying which of the following is the most frequent agent causing acute bronchiolitis. Now they're asking for the pathogen. So which pathogen is actually responsible? That's the only virus, RSV, respiratory syncytial virus. It's a clear-cut case where we just need to diagnose the pathogen. The second question says, a 7-month-old present with low-grade fever. Now the fever is there, low-grade, and a dry cough for the last 3 days. Now still the baby is having upper respiratory symptoms, right? It's mentioned low-grade fever and dry cough means upper respiratory tract is involved. On examination, there is wheezing over both lung fields. When you do the examination, you will appreciate crackers and you will appreciate wheezing. So that is another clue for you. Heart rate is okay, 127. It's okay in case of 7-month-old baby, a little higher side, but it's considered okay. Respiratory rate is high, so tachypnea is there, and of course fever is there. On chest X-ray, you will see hyperinflation and some infiltrate. So again, chest X-ray is diagnostic. In order to make a diagnosis, which of the following is the most likely diagnosis? So what do you think? What could be the reason? Is asthma, sinusitis, influenza, or bronchiolitis? So what was the important point in the ambers? The amber says if you look for the upper respiratory symptoms followed by the lower respiratory symptoms or the respiratory distress symptoms, like in this patient, the patient was having fever and dry cough for the last 3 days, and now he's developing wheezing. Now he's having tachypnea. So the lower respiratory tract is involved and chest X-ray showing hyperinflation. So that's a clear case of bronchiolitis. Why not asthma? Because shortness of breath is not there. The other features are not there. Sinusitis. Sinusitis is mostly the upper respiratory. You will not appreciate wheezing and everything in that case. It's just the upper respiratory tract infection. Influenza, it's a viral infection. It will not go beyond 3 days. It must be having a history of 1 day or 2 days, 24 hours or 48 hours maximum. So it's a case of bronchiolitis based on the symptoms, based on the examination and X-ray finding. Always remember upper respiratory symptoms followed by lower respiratory or respiratory distress symptoms, plus, of course, examination finding will help you making a diagnosis.
Why not influenza?
Sorry?
Why not influenza?
See, for influenza, the history should not be like this because in influenza, mostly the babies are having high-grade fever. High-grade fever within a 24 hours time period, the baby comes to you with a high-grade fever. But here he has already passed 3 days. The fever was low grade, and now he's having respiratory distress symptoms. He's having tachypnea. For the influenza, the baby should be within emergency department within 24 hours with a high grade fever of 106, 105. That is the temperature reading for influenza. And just a history of 24 hours. The patient was saying that yesterday's baby was fine, and now the baby is having a fever of 105. So that is usually the presentation of influenza because it's a viral infection, and the most vulnerable time period is 24 to 48 hours. It will never go beyond 4 days and 3 days. That not must be a history of influenza. Right? And other than that, there are some lower respiratory tract infection as well. Lower respiratory distress findings is there. So, for example, wheezing you can appreciate. Here you're appreciating wheezing. Tachypnea is there. In influenza, you will not find tachypnea. Tachypneic baby will not be there. Tachypnea is a sign of respiratory distress, where the lower respiratory tract is involved. In influenza, mostly the upper respiratory tract is involved.
There will be no tachypnea?
There will be but mild tachypnea. You will not find severe tachypnea associated with wheezing, not in influenza. Now, for this, we'll go for the theory first. Okay, so bronchiolitis. Next, we have croup. So let me take you 891. Okay. So this is an infectious upper airway condition. So for the bronchiolitis, you remember that was a lower respiratory tract infection, and here this is an upper airway condition characterized by severe inflammation. It is most commonly caused by parainfluenza virus type 1 and type 2, and syncytial is the second most common. So syncytial there in the bronchiolitis was the first and foremost one, but here croup, which is also again the inflammation of the upper airway, but that is most commonly caused by para-influenza virus type 1 and type 2. And what should be the presentation? The presentation of croup is very, very clear and very suggestive. You can easily make a diagnosis whenever the baby is having barking cough. The cough is just like, the baby is barking. Second, coryza, you will see the inflammation of the nasal mucosa, you will see the inflammation of the buccal mucosa, and inspiratory stridor. What is inspiratory stridor? When the baby, inhale, there is a clear sound while inhaling the air. That is inspiratory stridor. So if you can appreciate the inspiratory stridor, just, while inhaling, the baby is producing sound. When the baby is coughing is just like he's barking, and there's quite clear, inflammation of the mucosa, nasal mucosa plus buccal mucosa, that is coryza. So if these three things are there, so it will help you making a diagnosis of croup. So whenever it's mentioned inspiratory stridor, always, and barking cough, these two words are very peculiar. You will never find these two words associated with any other disease condition. They are only associated with croup. In inspiratory stridor and barking cough, they are very, very, very much associated with croup. The child will have more difficulty breathing when lying down and may show signs of hypoxia, such as peripheral cyanosis you can find, and accessory muscle use. You will see the baby is actually trying hard to inspire. That's why he's producing stridor also. Chest X-ray will show the classic steeple sign. That's a very important diagnostic finding. If it's mentioned that the steeple sign is observed on chest X-ray, what is your diagnosis? Think about only croup. You will never find steeple sign in any other condition. A narrowing of the air column in the trachea. So in the trachea, you will appreciate on chest X-ray that there is very narrow column of the air, and that is called steeple sign. So, however, X-ray is really done because the clinical symptoms are so obvious. We even don't want to go for the testing for the chest X-ray. But of course, when you do the chest X-ray, you will find this one. And it's always the wrong answer to the most appropriate X-ray. We will never go for the chest X-ray. We'll always go for the treatment. But of course, when you do the chest X-ray, you will find steeple sign, which is again diagnostic of croup. So, diagnosis is made clinically and can be aided by radiology if the symptoms are mild. But if the symptoms are strong, you will never waste your time in doing this chest X-ray and making a diagnosis. You will straight away go for the treatment. Hypoxia aids in differentiating croup from epiglottitis. Of course, hypoxia is there, especially you can appreciate with the help of this peripheral cyanosis. If you can see peripheral cyanosis in the baby, you can say hypoxia is there, and that is going to differentiate from epiglottitis. You will see epiglottitis after this one. For mild symptoms, give steroids. For moderate and severe symptoms, give Respiratory, epinephrine. So of course, if the symptoms are mild, we can go for the steroid, but if the symptoms are moderate and severe, straight away we have to give epinephrine, and once you do the treatment, the symptoms usually resolve. There you will not find anything on X-ray. That's why we are not wasting our time in doing X-ray. But once you do, you will always find steeple sign. So just memorize this thing, that what we are going to give for the treatment option, steroids and epinephrine. These are the two things. But of course, if the patient is presenting in emergency department, we'll always go for the epinephrine. So croup, hypoxia on presentation, epiglottitis, hypoxia imminent. So we'll see in epiglottitis, we will see the hypoxia must be there, but on croup will remain there in epiglottitis. In such a way that we have to intubate the baby. That's a surgical emergency. But in croup, it's just on presentation. Once you start doing your treatment, once you establish a diagnosis, when you start giving epinephrine, soon after this thing is resolved. But imminent means that there is no option. You have to go for intubation. You cannot waste your time for the treatment. And intubation is not giving much value. You will go for tracheostomy in case of epiglottitis. We will see in epiglottitis. So here, what we will memorize here in case of croup: barking cough, coryza, stridor, steeple sign, and treatment epinephrine. Just memorize these things. Now we'll see here the question, what they're asking. Which of the following sign on chest X-ray is most common in patients presented with croup? So that's only a one sign which is associated with croup. That's a Stipple sign. This meniscus sign is what? Meniscus sign is showing you that the air is accumulated between, if there is any mass or nodule in the lungs. So the air is accumulated between the lungs, between the normal parenchyma of the lung and that mass. So in between, you will see a sign that is called meniscus sign. Most likely, we will see meniscus sign in infection like aspergillosis, but not in the case of croup. Similarly, this spinnaker sign. Spinnaker sign. Have you seen that spinnaker sailing boat? So what is happening here in this spinnaker sign? Actually, the thymus outline you can appreciate, in which there are the air is on one side of the lobe and on the other side of the lobe, and in between there's just a shape which is just mimicking a shape of a spinnaker sailboat. We can say it's a spinnaker sign. So that is actually showing happening in mediastinum. So whenever there is too much air inside the mediastinum, then only we can see this spinnaker sign. Deep sulcus sign. Deep sulcus sign in the case of pneumothorax, you can see too much accumulation of air. So that is representing deep sulcus sign. So of course here in croup, it's very much obvious that we have stipple sign. That air is trapped inside the trachea and there's very narrow line inside the trachea. That's called stipple sign. If I can just show you on X-ray the stipple sign. So the trachea is there, and you see the stipple is there. So this stipple sign. Here you can see it. This narrow sign inside the trachea. Again, you can see stipple sign. Here also stipple sign.
ربيتك لأن ما هو مخروب.
Okay, so let's get back. Okay, now the most common cause of a stridor in children, the most common cause of a stridor, especially they're asking inspiratory stridor, that's the only one, and that is croup.
معروفة وغدة.
Okay, next one. Okay, most common cause of epiglottitis. For this one, we should go for the epiglottitis first. Epiglottitis will cover from 893. If you could just mute your mic, and if you want to ask anything, please unmute and ask that. That would be great. Okay. Epiglottitis is a severe life-threatening swelling of the epiglottitis, because it's very much clear that it is epiglottitis. So epiglottitis, inflammation of this one, epiglottitis, we will see here, and arytenoid cartilages. These are the cartilages of the trachea. So cartilages of the this one, and due to Haemophilus influenza type B. Now this is very important, that this Haemophilus influenza type B, while looking at this one, we may confuse that it's a virus. But please remember, this is not a virus. Haemophilus influenza type B, it's a bacteria. It's a gram-negative bacteria. And then influenza is actually a virus which is causing this influenza virus that belong to a category of RNA virus. Yes, RNA virus. But here, this Haemophilus influenza type B, it's a bacteria. So it's a very common recall where they're asking that which is the most common cause of epiglottitis. So that one is actually a bacteria. Most common cause is bacteria. This Haemophilus influenza type B, it's not a virus, it's a bacteria. So now we'll see here, look for a child with a history of vaccination, then we're going to see with hot potato. Now there's a very particular symptoms on the basis of which you can say it's an emergency, we have to intubate the baby. Hot potato voice is there, fever is there, maybe high grade, drooling in the tripod position. The baby must be in a tripod position, sitting down, showing this position, tripod position, and drooling. The saliva is coming out from his mouth because he is not able to breathe properly. Refusal to lie flat. He is unable to lie at all. So he will not lie at all. He is always doing his posture, bending forward. So hot potato voice, fever, drooling most of the time from the mouth. Baby will remain in the tripod position, will try to, squeeze his posture. He will not lie, he will refuse to lie flat. So that these are some symptoms and signs which you can see. It's a more pointing towards epiglottitis. So physical examination.
What will be hot potato voice?
See, hot potato voice means that see, once when we are eating very hot thing, what will happen to our voice? Just imagine that thing. If I'm just having some very hot bite of potato, very hot bite of something, my voice is there and I'm feeling pain while saying something, and I was just doing like this. Whenever I say, I will start something, this sound will come. So whenever there's something hot inside the larynx, especially the inside, over the trachea, over the larynx, what will happen? Because the larynx will get, something, the larynx will get air, the warm air and warm thing is there. And because of that, the sound is produced. Just before saying anything, the word will come, and then the baby says something. So it's a hot potato voice. It's showing that the baby is, whenever the baby says something, the first he has to produce some noise, and after that he's able to say something. That is called hot potato voice, and it's a very common feature because the baby is having difficulty in breathing. Why? This epiglottitis. You remember what is epiglottitis? It's a cover of the glottis, right? It covers actually the glottis, so that the food cannot enter into the trachea while deglutation, while swallowing, while eating something. The glottis should remain covered with the epiglottis. So this is the inflammation of the epiglottis. So what will happen? This trachea or this glottis is prone towards having something getting inside. So the patient has to do something just in order to close this one. Otherwise, the sound formation will not be there as well. That's a very, it's a surgical emergency. What we have to do in that case, we intubate the baby. We cannot waste the time in doing X-ray and everything like that. The clinical symptoms is quite suggestive that the baby is having epiglottitis, and we have to intubate the baby. Even if the intubation is failed, go for the tracheostomy. That usually these babies are intubated in operating OR room, recovery room, so that we are very close to operation theater. That if we need to go for the tracheostomy, go for the tracheostomy then. So it's a surgical emergency. So look for a child. So physical examination will reveal an extremely hot cherry red epiglottitis. When you do the examination, you can see by yourself that that epiglottis is too much inflamed, red, hot cherry like. So diagnosis is made clinically, but X-ray may reveal a classic thumbprint sign. You can see the thumbprint sign, but we should not waste our time in doing X-rays. So to treat, what we will do, we will intubate the child in the operating room. See, intubation also we should perform in the operating room. Why? Because the OR is the preferred setting in case unsuccessful intubation makes tracheostomy necessary. If there is intubation is difficult, we'll go for straight away for the tracheostomy. That's why we'll keep the baby in operating room. Now, administer ceftriaxone for 7 to 10 days. Of course, it's a bacterial infection. We'll go for the antibiotic for 10 days. And this is again very important point for exam point of view. Rifampin must be given to all close contacts. It's a bacterial infection. There are highly chances that this bacterial infection can progress into the siblings or the other family members. So whoever is close to the child, who is ever doing work, especially assisting baby, so that person should receive rifampin in order to avoid the prophylaxis, just in order to have a prophylaxis. So looking at the questions here. Most common, yes. Yes,
please show me the previous slide.
MTB? Yes.
Yeah, what is thumbprint sign? Show us on the...
Okay. I will show. Let us solve this one and I will show. Okay, most common cause of epiglottitis, you will see, just tell me, which is the one? Haemophilus influenza type B, and Haemophilus influenza type B, it's not a virus, okay, it's a bacteria. Most of the time I have seen this, debate going on over this Haemophilus. So Haemophilus influenza type B is a gram-negative bacteria. It's not a virus at all. That's why most common cause of epiglottitis is bacterial, not a viral. Now, a 4-year child is presented in an emergency department with high-grade fever, hot potato voice, drooling. Now, it's a very clear case, having all the symptoms, drooling in the tripod position, refusal to lie flat, hot potato voice, emergency department, high-grade fevers. What is the most likely diagnosis? It's clear case of epiglottitis. Which of the following medication should be given to all close contacts of epiglottitis patient. Which of the following should be given to all close contacts of epiglottitis patient? Which medication? Rifampicin is the one. So again, a very clear question. Okay. You want me to show you thumbprint sign?
Doctor, here the question is saying he has a bit hot voice and he's ask these signs. It was given in the question like this.
Yeah, it was a clear case. It's a very recent recall, having all the things. This was given. All the symptoms was given. See, everything is there.
Okay.
And simply they were asking the diagnosis. I want me to show you thumbprint. Okay, if you can just appreciate this one, maybe this one is quite. See, can you appreciate the thumb here, just like you're putting your thumb here? This one.
Yes.
Or maybe if you can see here, it's also clear here. See, it's just like the patient has kept his thumb like this. So this thumbprint sign is actually the inflammation of the epiglottis, causing epiglottitis.
It will become swollen?
Yes, too much, hot, cherry red, like it's inflamed a lot. That's why it's obliterating the passage of the trachea. That's why the patient is having too much. He will not lie flat because he will see that he will choke. There will be no respiration at all. Because you see, can you appreciate this? Too much narrowing. Very. That's why the wheezing is quite obvious.
Yes.
Okay. For the next one, we have to go for the theory scoliosis. So it's not very much in detail in MTB. So we'll go for Convexity. Scoliosis. So see, most of the time, scoliosis questions, they are asking you, whenever the child is a preschool child and there are some investigations, some tests for the preschool children, on that time period, usually the parents and the child, they come to know that they have scoliosis very, very early. Say, for example, school going age is like 3 years or 4 years or 5 years. So at that time period, the scoliosis is not very much enhanced, but it's starting. So scoliosis, what is scoliosis? It's a deformity of the spine characterized by lateral deflection and rotation of the vertebral bodies. So as soon as you detect them, it's far better, because as soon, once the time passes by, what will happen? The deformity will be too much. There will be too much deviation of the spines and the vertebrae, and there will be too much deflection of the vertebral column that, the braces will also not help. So as early as you can, pick up this one on X-ray or on examination, general physical examination, the better, the treatment will be. So it's a lateral deflection and rotation of the vertebral body. The disease typically present in patient 10 to 12 years of age and is seen more commonly in girls. The most common pattern of scoliosis is the right convex curvature of the thoracic spine. So right side, there will be a convexity in the thoracic spine. So the whole vertebral column is convex, like putting outside. The one side is totally in and the one side is totally out. That is how the convex is like. So it's a convex curvature of the thoracic spine, mainly resulting in forward rotation and protrusion of the right shoulder. So what you usually see, what you usually appreciate in later advanced stage, that the right shoulder is quite protruded and there's forward rotation of the vertebral column. So that is a typical presentation. And you can see, of course, in the advanced stages, but in the early stages, you can just, appreciate only on the basis of X-ray if there is any deviation.
Dr. Hira, sorry, please explain this position again.
See, this position is forward rotation. Just move your shoulder forward and outward. So the one shoulder, only the right side. The left side is a normal position. The one right side shoulder is quite rotated forward and outward. So the whole, body posture is actually going towards the right side. So you can see the clear demarcation, right? There's a whole deflection on the right side because the right shoulder is protruding outward and the whole vertebral column is shifted on that side. So there will be a clear, anyhow, the normal vertebral position should be a straight line. But in between, in the thoracic region, if there is too much deflection on the right side, then what will happen? It will be something like this. Let me show you on this one. Maybe you can. One minute. Maybe I can just do here. See, the normal should be like this one. Do this one. No, it's not allowing me to do. Anyhow, I will show you on Google because I'm not able to do it here. I cannot do it here. Anyhow, just imagine that the vertebral body is a straight, vertebral column is a straight one, right? There should be a straight line. But once if there is any deviation, so you can see it's clear. Maybe I should show you. So instead of saying, you can just have a look. See how it's look like? It should be straight, right? But here it's not showing straight. The cervical portion is okay, the lumbar portion is okay, but thoracic portion is going outward, rotated outward, declining outward, and this is called convexity, and it's mostly happen on the right side, right convexity. Can you see, Dr. Terry?
Yes, yes.
So that is actually this one. So this is X-ray, and again the body you can also see the patient is having the whole right side protruded outward and forward. So this is scoliosis. So coming back here.
In that picture, rightward or leftward?
This one?
Yeah.
It's here. If it's a PA view, so it should be this one should be left. Yeah.
If it's anterior, then it should be right. If posterior, then it should be left.
Left, yes. But most of the time,
left, yes.
Yeah, most of the time you will see on the right side. But again, it's not hard and fast. It may vary.
The next diagram, if it's from the back, then posterior view, then there will be right side. Or you on the right side.
Yes. So how you are going to differentiate based on this pelvic bones, you can appreciate. And here it's not very much clear, the pelvic bones. Even we don't see actually here.
But doctor, the hard shadow can also show us the right side.
Yes. Based on the hard shadow, you will say. Exactly. But only if you have this lumbar view, it will be difficult if you don't have the pelvic in front of you. Yes. Okay. So if you just go back and complete this one. So here it's saying, okay, so the most common pattern, it's again the most common pattern, but you will not find it as a hard and fast rule. Right convex curvature of the thoracic spine resulting in forward. We have done this one. Initially, patients do not experience any symptom. The disease is often diagnosed incidentally or following manifestation of obvious skeletal deformities. Since scoliosis is a progressive condition, later symptoms can include pain. So right now, in the beginning, of course, the baby or the child must not be having any symptom, but later with the advancement of the age, the pain can be there, the reduced mobility you will see, later on degenerative changes will be there in the spinal disc and vertebra. And in severe cases of spinal deformity, patient may show signs of pulmonary restriction, including difficulty in breathing and difficulty in breathing. Scoliosis is a clinical diagnosis that is to be confirmed by typical finding on X-ray. So here the X-ray will show corpse angle, and that should be more than 10 degrees. This is the corpse angle. So from where the deformity starts and from where from where the deformity starts and from where the deformity ends. Okay, Dr. Terry, you are on mute now. But once you want to ask, you can unmute, okay? So here the deformity starts and here the deformity ends. So once you just make a perpendicular here, so that angle is called as actually corpse angle. So this angle should be more than 10 degrees. If it's more than 10 degrees, we will say the scoliosis is there. Most of the time it's more than 10 degrees. So from where the deformity starts from here and the deformity ends here. So if you could just make a perpendicular here, we will say it's a corpse angle. And this angle should be more than 10 degrees. So here they are saying that that is the one clue for us, that on X-ray there should be a deformity, and of course it will be clearly obvious on examination. Treatment initially consists of observation and use of braces. So braces will help you as early as you detect. In cases of severe or rapidly progressing scoliosis, surgical treatment is necessary. Of course, once it's progressing, we'll go for the surgical one. Now, the very important point for exam point of view, which I want you to memorize here, is one of this test. This test is usually, the school children usually undergo this testing, and this test is called Adam Forward Bend test. We'll just ask the child to, what we actually asking the child here. The patient will ask her to bend forward at the waist and put his knees straight. So knee will be straight, and he will just bend his body forward, and that's how you're going to see whether there is any deviation in the posture or no. If there is any deviation, it means that scoliosis is there. If there is no deviation, the straight away the child is actually bending forward, and there is no deviation on any side. The baby's the whole column is in the middle. We will say it's a normal sign. So this is a very obvious test. Even you don't go for the chest X-ray and anything else, just by asking the child or asking the adult in which you are suspecting a scoliosis, you will just ask him to bend forward, and once he bend forward, knees are straight and he's bending forward. If there is any deflection on any side, we can say scoliosis can be there. And of course, when you do the X-ray, you will find it. So just remember this one, Adam Forward Bend test, and usually we do this testing in preschool children, especially in schools. They are usually performing this test just in order to see the posture of the baby. Okay, so going back to the question. Here it says, during physical examination of a child, the physician asks the patient to face the wall, bend forward, and let the arms hang down unsupported. The same posture. See, during physical examination of a child, the physician asks the patient to face the wall, bend forward, and let the arms hang down. It's okay. Let the arms hang down. That's a one more additional things they have mentioned here. Unsupported, of course, and if only the forward is bending, it means that the knees should be straight. So what does this test screen for? So you should know first the name of the test. The name of the test is Adam Screen Bend test. So what does this test for? Do you think it's for scoliosis, for sagittal abuse, for rectal prolapse, for leg length symmetry? So of course, it's a case of scoliosis. It's a clear test when we ask the patient to bend forward. This thing they have just mentioned just to confuse you, let the arms hang down as unsupported. Of course, the arms will be unsupported and knees should be straight. So these three things we will ask the children or ask the examinee, and then you will observe if there is any deflection in the posture, we will say a scoliosis is positive. The test is Adam Forward Bend testing, and this is the test to screening for scoliosis. And other than that, there are usually recalls which says Cobb's angle. Recently, I didn't find any one, but in the previous one, so the Cobb's angle, you must remember it should be more than 10 degrees in order to make a diagnosis of scoliosis. So this is all about today. Thank you so much. See you tomorrow. Thank you, everyone. Let me stop the recording.
Thank you, Dr. Hira.